This dashboard is the modern healthcare executive's command center. Specifically, this executive information system tracks critical key performance indicators. By monitoring data points like wait times, schedule utilization, and no-show rates, leadership assesses organizational health with a quick glance. But the clean, highly structured graphics on this screen stand in sharp contrast to the chaotic, high-stakes physical reality of a functioning hospital. Bridging the gap between the physical hospital and these executive charts is a massive, hidden digital infrastructure known as administrative information systems. Every clean line and perfect dial at the top level is entirely vulnerable to invisible data failures occurring at the ground level. A single misclassification in the basement can corrupt the executive overview in the boardroom. To understand how a modern healthcare organization survives, we have to reverse engineer this dashboard. We need to travel downward through the data pipeline, moving past the financial engines and analytical models to the absolute bedrock where a patient first enters the facility. The executive dashboard provides an illusion of control. True operational control is dictated entirely by the structural integrity of the underlying data stack. Take a metric like patient visits. To understand how that number populates, we have to isolate exactly where the first piece of data originates. That point of origin is the RADT system: registration, admission, discharge, transfer. It captures the initial demographic and insurance data the moment a patient walks through the doors. The RADT does not store this information in isolation. It feeds directly into the most critical database in the entire hospital, the Master Patient Index. The Master Patient Index, or MPI, is a legally mandated permanent directory. It serves as the primary link to a patient's health information, maintaining a single longitudinal record from birth to death. Poor data entry here carries massive operational risks. If admission staff incorrectly assume two distinct patients are the same, they create an overlay, intertwining their medical histories. If an established patient is assigned a new record number, their history fragments into duplicates. To defend against these identity collisions, hospitals rely on automated safeguards built into the MPI, specifically phonetic algorithms. A Soundex algorithm scans incoming data and intercepts records that sound alike phonetically but are spelled differently. If it catches an alternative spelling, it halts the process and flags a potential duplicate. When the algorithm flags a collision, automated processes stop. Health information management staff must manually intervene to investigate, merge duplicate numbers, or separate overlaid health records. For massive integrated delivery networks spanning multiple hospitals and clinics, this requires an enterprise master patient index to track a single patient across entirely separate geographical databases. Without flawless data governance at this exact point of entry, every subsequent clinical and financial system attempts to build upon a fractured foundation. Once patient identity is secured, the organization must accurately capture the revenue generated by their visit. This is handled by revenue cycle management. RCM is the daily administration of accounts receivable and accounts payable, the lifeblood keeping a hospital fiscally solvent. The core of that cycle is the charge master, a translation matrix converting clinical procedures into billable financial codes. If a nurse runs a COVID antibody test, the system maps it to HCPCS code 8143, generating a precise charge of $225. That $225 charge flows out of the charge master, posts to the patient accounting module, and registers in the general ledger. The vulnerability in this automated revenue engine is its rigid reliance on exact classification codes, which are updated annually by federal and medical authorities. If the ChargeMaster software is not updated on a strict schedule, the hospital will submit outdated codes. The immediate result is widespread claim denials from insurance providers and a catastrophic loss of revenue. Furthermore, the automated coding process relies heavily on clinical documentation integrity. The billing output is only ever as accurate as the physician's initial medical notes. The ChargeMaster acts as the single critical bottleneck for the organization. Medical effort is either successfully converted to cash here, or it is lost entirely to coding errors. Executing the procedures billed through the ChargeMaster requires mobilizing a massive amount of physical resources. The Human Resources Information System tracks the availability of the required personnel. It monitors payroll, tracks absenteeism, and ensures that clinicians possess the proper active medical certifications. Meanwhile, the materials management system controls the physical supplies. It enforces departmental budgets, generates purchase requisitions, and routes them through the necessary chain of command for approval. Materials management software uses automated thresholds to execute just-in-time purchasing, automatically ordering specific surgical kits only when the physical inventory drops below a predetermined number. Both the personnel data from the HRIS and the supply data from materials management must converge into a centralized scheduling system. The scheduling system's job is absolute synchronization. It ensures the credentialed surgeon, the physical operating room, and the sterilized equipment all arrive at the exact same moment. Tracking thousands of personnel movements, supply orders, and facility reservations daily generates an overwhelming amount of raw operational data. Patient care is a highly complex logistical puzzle. These operational systems synchronize physical resources to prevent idle equipment, eliminate supply shortages, and avoid costly surgery cancellations. The MPI, the charge master, and the scheduling systems operate continuously, generating an immense scale of daily administrative and clinical documentation. The sheer volume and diverse format of this information bypass the processing ability of traditional relational databases, creating unstructured repositories known as big data. To extract meaning from this raw repository, organizations deploy business intelligence tools. BI analyzes the raw performance data, filtering it for quality and transforming it into actionable insights. A key component of this analytical layer is the decision support system. While other systems handle routine administration, the DSS is used specifically by management to solve non-routine, unstructured problems. The DSS does not schedule staff, and it does not order inventory. Instead, it relies on prescriptive analytics. It runs complex what-if models against historical data to forecast future outcomes, allowing administrators to evaluate the projected profit and loss of adding a completely new geriatric center or expanding the emergency department. These refined DSS models and business intelligence insights are then aggregated and pushed upward to the ultimate decision makers. Together, business intelligence and decision support systems serve as a vital translation layer. They turn a chaotic, massive operational history into focused, actionable foresight for hospital leadership. If we follow that refined intelligence back up the pipeline, we return to the very top of the data stack where our journey began. We arrive back at the executive information system. Only now, the clean charts and performance dials carry their full context. This dashboard is merely the visualization layer. It rests entirely on the integrity of the MPI algorithms identifying patients, the charge master capturing revenue, and the DSS forecasting growth. A healthcare organization's strategic agility does not originate in the boardroom. It depends completely on the rigorous data governance executed at the lowest operational levels. This makes the health information management professional the architect and guardian of this entire pipeline, securing clinical documentation, auditing revenue cycles, and ensuring data quality. Failing to maintain strict oversight of the index algorithms or the classification codes guarantees that the executive dashboard will simply display a dangerous, expensive fiction. In the modern healthcare landscape, managing the business of healthcare is managing the data of healthcare.